So how do we determine who to give this treatment to, who to prescribe medicinal cannabis for? Cannabis is a very versatile medicine and may be a useful tool when conventional medicines fail or become ineffective at relieving side effects or are unable to be taken due to increased side effects of those medications. Due to the uniqueness and heterogeneity of every person's endocannabinoid system. So everyone in this room has an endocannabinoid system, and everyone in this room has a slightly different endocannabinoid system, and everyone in this room will respond slightly differently to cannabis medication when it's given. So treatment of patients with medicinal cannabis should be done on a case-by-case basis, a person-by-person basis, and should be patient-centered. The initial assessment is standard history and examination. We want to address patients' expectations. Do they expect a cure for their disease, or are they looking for symptom amelioration? And we must be realistic about what we can do with this medicine. As Teresa noted, it's not the magical pill, but it does have its place and it is very beneficial. For instance, at this stage, there's a lot of anecdotal evidence, and I'm sure you've got patients that have already come to you looking for cancer treatment, cancer cure from medicinal cannabis. And though overseas there is a lot of observational evidence, there is a lot of studies being conducted and much theorising that cannabis, yes, it could be useful in cancer. In Australia, our guidelines say that the answers aren't in yet and we can't provide that cure. We can, however, ameliorate their symptoms. So this is something we have to take into consideration when treating our patients. The affordability of our treatment, it's expensive at the moment, and that's purely due to supply and demand, I think. If you're dosing a small child at 150 milligrams of CBD daily, the cost of that is exorbitant at this stage, and the majority of patients actually can't afford it. So we have to look at that. With new companies coming into the market, prices are coming down, but still in the region of $1,000 a month would be a good guess at treatment costs for most diseases. And when using, as we say, small amounts of THC for pain relief, these treatment costs can come down to $300 a month, perhaps. But I think that's a minimum at this stage, so cost is something you have to think about and explain to your patient and explain that, it's not on the PBS at this stage and I can't just give it to you. We need to formulate and explain our treatment goals to the patient, and these include control of symptoms, our aims to improve quality of life, and the aim to improve the side effects associated with polypharmacy, which is so common in today's medical practice. And importantly, we need to document things. We have to document everything, as we know anyway. But this becomes very relevant in the case of applying for medicinal cannabis, which I will go through at the end of my talk. But we need to document the current treatments, whether they're working, whether there's side effects, the previous treatments, whether they worked, why they were stopped, what the side effects were, and any other interventions which the patient's undergone, because this is used as supporting evidence in the supporting letter for applications. So it's very important to take these down, especially the reasons why the first-line treatments have not been effective. At this stage in Australia, cannabis is a second-line treatment and can only be used when first-line treatments fail. So it's very important that we stipulate this in our applications. So when conventional treatments fail or are ineffective and side effects make treatments intolerable, I think medicinal cannabis should be considered as a very good treatment option. A risk versus benefit analysis should be done, as is always the case for any medication. And if the potential benefits outweigh the potential risks, then I think you're very safe to go ahead and prescribe medicinal cannabis. So currently in Australia, at the beginning of this amazing component of medical history, I believe, we're approved to prescribe for patients with epilepsy, spasticity associated with multiple sclerosis, importantly the spasticity associated with multiple sclerosis, chemotherapy-induced nausea and vomiting, and in the palliative care situation. Though the standard application process at the moment through the TGA is for any unapproved medication for any disease, as long as we can justify it. So pain, though not actually approved, is getting through 35 cases from Dr. Taupik in New South Wales. I myself have got a post-traumatic stress disorder patient that has recently received approval. So how we apply for these medications is guided by this, and they must be taken into account. For instance, if you say, I want to prescribe medicinal cannabis to cure this patient's breast cancer, you will not get approved. If you say, I wish to prescribe medicinal cannabis to alleviate the chemotherapy-induced nausea and vomiting associated with this patient's treatment for breast cancer, you will get approved. It's a word game. But I do believe this is changing at the moment, and hopefully the Queensland access will get easier. I'll get to that in a minute. So, treatment considerations. Cannabis is a multi-target drug, and it may be used to treat multiple symptoms and conditions simultaneously within the human body. And it is beneficial in reducing polypharmacy. And the importance of whole plant medicine can't be overstated. This is the entourage effect elucidated by Dr. Taupik and coined by Professor Raphael Mechoulam, the grandfather of medicinal cannabis in the world. He's still alive, based in Israel. And it's not just the THC, it's not just the CBD. It's the way in which all those other components in the plant, the other cannabinoids, the terpenes or the aromatic components of the plant, which are found in all fruits and vegetables, and they're the nice things we smell, and the flavonoids. And the way that these compounds actually modulate binding of our own endogenous endocannabinoids and modulate binding of exogenous or the phytocannabinoids, the plant medicines which we're administering. So there has been negative effects, and dronabinol as a synthetic compound, as a THC receptor agonist, but it actually has 100% binding affinity. So standard medicinal cannabis does not have 100% binding affinity to the CBR receptor. It binds in a modulatory fashion, and that modulation is actually controlled by interaction with the other chemicals in the plant. So what they found that yes, this really did work as an appetite suppressant for patients, the dronabinol, and it was helping people to lose weight. Unfortunate side effect was severe depression and suicide. So this drug was quickly taken off the market. And this just stresses to me the importance of Chemo Vars and strain of plant, which is where we get our true cannabinoid ratios from, and I'll explain that more in a second. So the metabolic pathways of every person have to be taken into consideration. Every person's endocannabinoid system is unique. And genetic variability results in slow and fast metabolizers of medications generally. And this does include cannabinoid medications as well. So we've touched on the cytochrome P450 enzyme and liver metabolism. It's very important. We must keep this in our minds. And each individual patient, with the introduction of medicinal cannabis into their treatment regime, it may be necessary to increase or decrease their conventional medications, and you may require more or less cannabinoid medication than you're expecting due to this heterogeneity of the endocannabinoid system and people's genetic response. So drug interactions have been fairly well covered earlier in this talk with regards to the liver metabolism and cytochrome P450. And I think dosing, we also need to consider what happens when you take a drug orally and the fact that you're going to undergo portal hepatic circulation and then immediate metabolism of your cannabinoid medicines by your liver, as opposed to, say, the sublingual absorption. So route of administration is very, very important to understand. And the route of administration affects bioavailability, the onset of action, the duration of action of the medicine, and in fact blood plasma levels of the medication, medicinal cannabis. As noted, smoking is just not recommended in Australia for obvious reasons, but that does leave us with many options as to route of administration. So inhalation, quick onset, short duration, good effect. Oral, some metabolism by the liver, longer duration, say 4 to 6 hours, 1 to 2 hours onset. Sublingual, the studies on sublingual sort of show a similar profile as oral absorption, but that would be probably more through the patient swallowing the medication than getting 100% sublingual absorption. The theory of sublingual administration is we do avoid that portal hepatic circulation initially, so we have a longer duration and more effect from our cannabinoid medicines. Rectal suppository is another option. Not so relevant at this stage in Australia, but when cannabinoid medications are used in high doses, as is in the case in overseas, in many situations, to avoid the psychoactive effects of THC, high doses of cannabis can be given as a suppository, again avoiding the portal hepatic circulation. It's in the last inch or so of the rectum there. And high doses of THC can be given with extremely reduced psychoactive effects. So at this stage, it's probably not going to be relevant for us as practitioners, but as we progress in this field, I think this will become a relevant administration method, as will transdermal patches for people. They're not readily available in Australia yet, but overseas, there's definite use for these methods of administration. So all methods of administration have their own positive and negative effects, and should be aligned with the individual patient and disease process to be modified or the symptoms to be relieved. The bi-directional effect of cannabinoid medicines is very important as well. So dose is important. It's not more is better with this medicine. Variations in cannabis dose can produce, in fact, opposite effects. So, for example, low doses of THC can alleviate anxiety, whereas high doses of THC can exacerbate anxiety. So we have to take this into effect when we're prescribing. And consistent cannabinoid profiles. So when we refer to whole plant medicine, we mean we take a plant, remove its flowers, extract the cannabinoids out of that, not just the THC, not just the CBD, but the terpenes and the flavonoids. I know I'm repeating myself. And all these are components of the medicine, which then has a greater than an individual effect, the entourage effect. And we have to make sure we've got access to high quality, organically prepared cannabis. At the moment in America, in states especially where it's become just recreational legalized, there's a lot of problems with pesticide contamination, heavy metal contamination from hydroponic growth mediums used incorrectly, fungal contamination causing respiratory problems in patients. So good manufacturing practice, or GMP, is imperative, and all Australian producers have to abide by these laws. And when we're talking to them, we have to ask them for these profiles so that we can be educated on the best way to use their medicine, because each product from each producer will have slightly different effects on different individuals. We need accurate and reproducible cannabinoid and terpene profiles for their medicines. So if their medicine's called medicine A, and we order medicine A for that patient, and we get it next time and it's A plus a little bit something different, that's not medicine A anymore. They have to be reproducible, and this is very important for ongoing patient treatment. And in fact, studies in Israel have shown that where children have had great effect on a certain strain or Chemo Vars and a certain cannabinoid profile, when these profiles have been slightly changed by the grower and they say, yes, this is the same one, but when the profile has been analysed, the actual cannabinoid ratio is different, and that's shown a increase in seizure activity in those children from their effective dose. So the Chemo Vars is relevant, and in fact, one Chemo Vars may not be effective, and then we can swap that out for a similar ratio product, and that may be effective. So this is, again, the individuality of the endocannabinoid system. So the biphasic effect, this is one of the bidirectional effects. So high and low doses of cannabinoid preparations can produce varying effects, and this can be used to our clinical advantage. For example, in a patient with an insomnia and depression, a low dose THC given in the morning may in fact produce elevate mood, and high THC doses in the evening may be used to produce sleep. So more is not always better, and we should take care there. CBD, the lesser known component of medicinal cannabis, no known side effects, but used at higher doses, so we must be aware of potential of drug interactions. And combined cannabinoids are better than isolates. This comes back to the entourage effect and whole plant medicine. Due to plant breeding throughout the Prohibition era since 1940, there's been a focus on strains which are high in THC for recreational or adult use. Now, strains which actually have relatively higher levels of CBD seem to be more effective in the medical cannabis clinical perspective. And this, we deal with the ratio between THC and CBD here. So 1:1 is a very good general ratio, but we've found that for pain and spasticity and insomnia, products with higher THC relative to CBD are more effective. And in fact, areas such as epilepsy and inflammatory conditions, high CBD formulations are seen to be more effective. That's Charlotte Figge again, we've talked about that. That's a high CBD strain, 0.3% THC and up to 20% CBD, made famous in the treatment of epilepsy. Pharmacokinetic considerations. I'm just moving along a bit because we're running short on time, but the route of the administration is very important. We've covered that. And the fact that cannabis is a fat-soluble molecule, or collection of molecules, so it should be administered in an oil or potentially with fatty meals, but I think an oil is the best way to do it. And the molecules are distributed mainly via blood flow, so high blood flow tissues get more medicine initially, the brain, the muscles, and then it progresses to be stored in our body's lipids. So Chemo Vars, we've touched on this a few times, and it is very, very important. This is the basis of cannabinoid medicine, and selecting Chemo Vars is in fact probably one of the most important aspects of our job as medical practitioners. We've got the multiple components in there, and we've got different ratios of cannabinoids and terpenes in each one. And this will affect how the medication works for people. So, as I mentioned, THC and CBD are the main components, but how THC in particular binds to the receptors is modulated by these other components in the medicine. Terpenes are a very important area. Things like linalool, which is the smell coming from lavender, they're associated with relief from anxiety, calming effects. Things like limonene, which are found in citrus plants, are found to be more energizing. Terpenes such as myrcene, which is the smell you get from mangoes, are found to be very good at pain relief and actually are quite sedating. So these need to be taken into consideration as well. There's not enough time here, but I'm sure we'll be able to find out more about that later. But we also have to consider the difference between indicas and sativas as in strains. So these are things which will be all outlined in cannabinoid profiles, which we must ask for from our producers. So we have to have a patient-centered approach. Each patient is unique. We must address their desired outcomes and needs of their treatment. And we have to be careful, especially in the cannabis-naive patient. We have to look at their psychoactive components of the drugs, especially in these patients, and perhaps reduce their initial dosing and slow their titration. And information is very important to a positive outcome in these patients. So letting them know about the side effects, empowering them to help titrate and let you know if they're having problems, and to step back one level of titration if you are starting to receive too many feedbacks of bad side effects. We need to think of timing when it's given during the day. As we say, we don't want people to be asleep in the morning. Perhaps it's better to give THC at night. We need to think of the lifestyle of the patient. Are they driving? Are they at home? And it doesn't matter if they're a bit sleepy as long as their pain's gone away. All these things have to be taken into consideration, as do their current medications. So nighttime is a good time to start, especially a cannabis-naive patient, on THC products because they'll fall asleep generally. It's slightly sedating and then they're not going to experience any negative side effects. Whereas if you started a cannabis-naive patient high-dose THC in the morning, they're more likely to be confused, paranoid, or have an adverse side effect. So education is again very important. So we need to start low and go slow. This ameliorates any potential of psychoactive effects. We start with a very small dose and allow for gentle titration up. This also allows patient tolerance to occur like any drug, and a reduction in these side effects which are deemed negative. Very important in naive users. As a rough guide, 30 milligrams a day is a general maximum dose for THC, and CBD can be really quite high, but we should still again start low with CBD and titrate high. And once again, patients may require slightly more than 30 milligrams per day to alleviate their symptoms. We just take this into account. So CBD has a very low toxicity and is not psychoactive. And in epilepsy patients, up to doses of up to 15 milligrams per kilogram per day are quite normal. CBD, large doses are safely tolerable. So start low, 2.5 milligrams, 1.25 milligrams, go up by 2.5 milligrams every few days until we get to an effective dosing level. Sativex is an oral mucosal spray which is actually on the ARTG, and if there's any neurologists here, you'll be happy to know that you can actually prescribe Sativex to your patients without need to run through the TGA process. But all other cannabinoid medications at this stage still need to run through the TGA process. So Sativex is what a lot of the initial studies have been done on. It has a 1:1 THC as the CBD ratio. So 6 to 8 sprays a day has been seen to be effective in MS spasticity with a maximum of 12. But at this stage it is very expensive in Australia, with dosing costs in excess of $1,000 a month. Once again, smoking is not recommended, though vaporizers provide the similar sort of pharmacokinetics. Take a dose from an inhaler, wait 15 minutes, take another dose, continue until a good dose is achieved. Start low, go slow. Start low, go slow. That's the easy way to do it and the easy way to avoid side effects. Low doses to start, slow titration. Empower your patients to keep a diary of medication, keep a diary of side effects, so you can look back over that diary and say, okay, this is where it seemed to be less effective and more side effects were coming on. This is the area we need to stay, and it gives you a very good guide. So I'll quickly finish off on prescribing in Queensland as we're running out of time. Unfortunately, in Queensland, at this stage, it is not quite as easy as New South Wales, though I do hear in the grapevine and through college pressure and prescriber pressure, I think this will change quite quickly. At this state, we still require a state approval and a federal approval in Queensland. Both forms can be filled out simultaneously, but at this stage, Queensland Health will definitely not approve any prescription without a letter of support for a trial by a specialist. As we know, this has its own inherent slowdown to the system and is causing a lack of approvals coming through in Queensland. Though it still can be done, and I think it's more of a case of education. With the paperwork, especially for the Queensland part of the application, we have to stipulate a review schedule, so see the patient at 2 weeks, 4 weeks, 2 months, 3 months, ongoing monitoring. We have to show our monitoring and dosing plans are relevant, so include a patient diary as part of your monitoring plan is a very good idea. Monitoring any side effects. And importantly, and I think this is the key to getting approvals across the line so far as I've seen, is that cannabis medicine is not considered a first-line treatment by Australia at this stage. Therefore, we have to indicate that it is a second-line treatment. We have to document the areas and the medications and other treatments which have failed. So basically, for relief of symptoms not previously currently ameliorated by, list your medications. Comment on side effects which are intolerable, and even put in your wording. As such, I think a trial of medicinal cannabis of this product at this rate is applicable for this patient, a trial. And this is little wording tips which I've developed in my practice, and I've seen good results there. So that concludes the RAC GP component of the seminar today. And I'd like to thank you all coming, and I hope we provided you with a good introduction to medicinal cannabis and empowered you to feel more able to prescribe to your patients. I am more than happy to give advice or take referrals or help with any way that I can with all of you in getting these applications submitted, or if you want advice on dosing or any of the things which we've talked about, please feel free to contact me. I haven't got a slide, but my email is info@drteh.com, DRTEH. Come and talk to me after the presentations, grab a card. And I'd really like to thank Adam Benjamin and MediFarm for putting on this event. I'd like to thank the council, and I'd like to thank MediHuanna for getting this recognised by the RACGP. And most importantly, I'd like to thank all of you who have come today, taken time out of your day to learn and be the pioneers in this burgeoning area of medicine, which I think is going to become so important in the near future and the long-term future. Thank you very much.